So it is Friday, June 25th, 2021, and it's the review session once again. Huzzah. Had a couple topics requested, and then I've got some specific, or not specific questions, but some harder questions put on a Quizlet prepared for you guys. So we'll see how it goes. We'll start with the PowerPoint. So the couple things that I had asked for were pathological gait patterns, joint capsules and capsular patterns, active versus passive insufficiency, and then talking about both cardiac and neuropathology, dealing with the left side of the heart or the brain and then the right side of the heart of the brain. So those are the main topics for today. That was what I had requested. And then, like I said, I've got some challenging questions coming up at the end here. So we'll see how that goes. So first of all, with pathological gait. One thing you need to know for pathological gait for the board is to pay attention to what the patient's deficits are and how to compensate or treat them. Remember that most pathological gaits stem from either a weakness, a stretch weakness of muscles, a group of muscles being tight or spastic, or a combination of both. So the presentation of a pathological gait could be musculoskeletal in origin, such as somebody that's got foot drop, right? Where that's just that their foot is just not clearing whatever, maybe their tibialis anterior is not strong enough. It could also be neurological in nature, being that the nerve 2 tibialis anterior is no longer functioning. Or it could be a little bit of combination of both those. The presentation of the pathological gait will be the patient compensating for the gait abnormalities. And those abnormalities will increase energy expenditure and safety or decrease safety. So the goal of your questions or goal of anything to encounter in pathological gait should be focused on energy expenditure conservation and then increasing the patient's safety. So maybe providing them with assistive devices or correcting the muscles that are causing the problem. So the most common pathological gait problem you're going to get, obviously, is with lateral trunk bend, or otherwise known as gluteus medius gait, right? This is when the patient is observed kind of trying to reduce the load during ambulation. So when they get into stance phase, when one leg is elevated, one of the sides will drop just like that, just like the Trendelenburg sign shows. That will actually show up in their gait. So as they're walking and one leg picks up and starts swinging through, that pelvis will drop. And oftentimes they'll get a shortened stride length because of it. When you get that view and you see that one side drop, so if my right side of my pelvis drops during gait, it's the contralateral, it's the other side's hip abductors that are weak. So if when I'm walking, my left side swings through and it drops down, that's going to be a right Trendelenburg, meaning the right glute med is the problem. Now, the way they'll compensate for that is with lateral trunk bend. So when you test them with Trendelenburg sign and they stand on that one foot, it'll drop. So what they'll do to compensate for that is when they're walking, they're going to lean way far over and activate QL. So they use QL to substitute for, hold on here a second. I just had somebody asking for the code for my Zoom and I don't remember it off the top of my head. So I've got to look it up. It is, there it is. Hold on here one second. There we go. So again, with standing in place, when I lift the leg up, if I'm just lifting that leg and that pelvis drops, that's a Trendelenburg sign of the contralateral hip. So that would be if my left leg is up and drops, but my right leg lifts up and is fine, then that would be a right Trendelenburg, and the problem is the right gluteus medius. Gluteus medius is the weak part. But during gait, the way that I'm going to compensate that is with a right trunk lean. So I'm going to bring that trunk way over that right leg in order to allow for swing through without the pelvic drop. Otherwise, as soon as I get to mid swing, my pelvis is going to drop and my foot's going to hit the floor. So I lean towards the side that's weak. And with every single gait pattern here that's pathological, I put at least one demo video that you guys can watch at a later time. Trendelenburg Gait or gluteus medius gait can also be called waddling. There is a difference between Trendelenburg Gait and Trendelenburg Sign. And the major difference is Trendelenburg Gait is truly the lateral trunk bending gait gyra. So when you have Trendelenburg Gait, the patient is leaning with the trunk. The sign is what we're going to detect in order to see why they're leaning.
Mr. McKeever?
Yep.
So I've seen a lot for like Duchenne's muscular dystrophy, they have what's the waddling gait. Is that just Trendelenburg then?
No, that's actually why I said this is called waddling, but this is not waddling gait. We're going to talk about waddling gait in a little bit.
Okay, cool.
So the reason it's called waddling is because they're kind of doing like a penguin down the road as they bend their trunk side to side, right? So to answer Gyra maybe a little clearer, if Gyra is watching me walk and sees me heavily leaning to one side when I walk, his next goal should be to test it for Trendelenburg sign with me, which would be the next part, right? Where we look for contralateral pelvic drop. So he's going to go put me on the wall, have me put my hands up against the wall, have me lift one leg, see if I'm able to hold that leg off the ground. Good. Then have me lift the other leg and watch. Boom. There goes my trunk drop. And you're like, oh, okay, so you do have Trendelenburg sign, which leads to Trendelenburg gait. And then we know that, oh, if my right side dropped, it's my left hip abductors that are my problem. And I need to strengthen those left hip abductors. At the same time, oh, go ahead, Sukana.
So basically when we see it, like if it drops to the right, means the left side is weak.
Yes. Yes, it's the opposite side that's weak. Because what's happening is when I lift this right side up, my left side has to fire in order to hold me in that position. Or I have to trunk lean way over. Okay. Right? If neither of those happen and this side and my pelvis drops, it's because this side can't hold me isometrically.
Okay, got it.
Right? Yep. And it's a combination of it's really technically a combination of isometric and isotonic contraction, because initially when I'm lifting that leg, it's an isotonic, it's a concentric contraction of the glute med. And then once I get the leg in the air, it's an isometric hold of the glute med. So they have to have functional kind of isometric and isotonic control of that glute med, which means we need to work a little bit of both, right? We need to work a little bit of concentric contraction of kind of hip abduction. We also have to work some isometrics on that side for stabilization. Does that make sense for Trendelenburg at least? Okay.
Yes.
So then we've got most of the rest of the pathological gaits are named for the way that the patient positions themselves over their muscles. So posterior trunk lean or glute max gait. Posterior trunk lean, I'm going to lean way back, which means I'm leaning over my gluteus maximus. It's typically seen during early stance phase, early swing phase, where the patient leans posteriorly to move the gravity line behind the hip joint. So when I'm walking, I'm going to kind of lean back, lean back, lean back. This is kind of like the Fat Joe gait. I'm just joking. That wasn't an insult on him. That was a rapper. Okay, I appreciate Jaira laughing at me. Right? So this is where what happens is at that point, typically, what's happening when you lean back is either have weak quadriceps or tight glute maxes. So the quadriceps being weak would, when you go in the stance phase, would lead to those glute maxes kind of pulling, overpowering the quadriceps. Or it could be because the glute maxes are super tight and they're not allowing the quadriceps to control things. So a lot of times when we're looking at that bilateral glute max gait here, my problem is either, you know, weak quads or tight glutes, or it could be a combination, right? Maybe my quads became weak, and because my quads became weak, my glutes eventually went tight. So that would be a strengthen this and stretch that. And then also correct posture so that they're upright during gait, right? And that's going to help that. Quadriceps gait is kind of the opposite of glute max gait. In this case, I'm leaning forward when I walk. So I'm kind of hunched over almost. Now that's not the same as having a kyphotic posture while they're walking, right? Kyphotic posture is up here, right? Up here in the chest. That's a kyphotic posture, right? A glute or a quadriceps gait means I'm leaning at the trunk over those muscles. It's usually seen most during stance phase, and honestly, a lot of our gait deviations are going to be during stance phase because that's when we either have isometric holds going on or eccentric loading going on. And why might that be a problem? Well, the problem here is I've got either tight quads that are pulling me way forward, or what would go along with tight quads? Weak what? It'll be the opposite of the quads. Weak hammies and glutes, yeah. So weak hammies and glutes, right? Because remember that the glutes are a primary hip extender, right? So if I've got kind of some trunk flexion going on there, they're part of it. But it could also be very much tight or weak hamstrings as well. So that means we're going to spend time stretching out those quads really heavily, right? What special test could we do to determine if it's tight quads or a weak hammy? Thomas test, good, right? Thomas test is going to tell us if we've got tight quads, right? So if you were to do a Thomas test and you get a negative result on both sides, that tells you that the problem isn't the quads, the problem is the hamstrings. Does that make sense to everybody? Right, okay, good. Because what basically we're doing at that point is ruling out things. Now, let me ask you the second question to that. What if we do a Thomas test and we get a positive result? Does that mean we don't have weak hamstrings? No, right? It could be that we have both, right? But what we're trying to do at that point is just rule something out. So hopefully that we can say, okay, you know, maybe we do this quadriceps gait and we test the Thomas test and they don't have tight quads. We can go, okay, the only thing we really need to work on is strengthening up those hammies. But most times in the real world, what you're going to do is you're going to do that Thomas test. It's going to be tight and you're going to have some weak hammies back there. So we can turn the Thomas test into a stretch. We can do kind of the kneel stretch or the long lunge stretch. There's all kinds of stretches we can do to stretch out the quads, right? And then hamstrings, we can work on doing stuff like curls and hip abduction or hip extension activities.
Mr. McKeever, for the interior trunk lean, is it same as the, is it called suspended gait when your trunk is leaning forward too much?
Yeah, I mean, it's pretty rare that it's called that, but yes.
Okay, is the same?
Yes, it is. It is the same. Yes, suspension gait. Yeah.
Okay, thank you.
Excessive ankle plantar flexion. So this is not due to tight. So this one here is not due to tight plantar flexors, although it could be part of the way. This is just you're observing excessive ankle plantar flexion during stance and swing phase. It's called vaulting. And this is where during stance and swing phase, they lift up onto their toes on one of their foot. Why are they doing that? They're lifting up on their toes to clear the other foot's toe drag. So it could be due to the other foot having weak tibialis anterior, it could be foot drop, could be any number of things that's causing this, but it's typically single-sided. So when you watch them walk on their left foot, looks normal. They go over to that right foot, and when they go to that right foot, as that left leg swings through, they kind of come up almost like they're a dancer on the ball of their foot. That's what excessive ankle plantar flexion gait is. And the reason for it is either A, they can't get any knee flexion on that opposite side. So it could be weakness in knee flexion. Or it could be problems with tibialis anterior. And so that's when we're going to come down, and we haven't talked about it yet, but if it's problem with tibialis anterior, we're going to look for stuff like foot slap when the foot touches down. Or foot drop, totally, foot where it just completely collapses. The idea is to avoid that other side. Or maybe the leg just can't hip flex enough. So the problem is clearance of the opposite foot, right? So this is clearance of the opposite foot. Now, also on top of that, if this doesn't happen, I can also do this down here, which is circumduction. So instead of coming up on the ball of my foot when I'm in stance phase, I can just swing the leg way out to the side. So either of those could be a valid compensation for any of these problems up here. So what I'll do is, well, I can't clear my toes, so I'll either come up on the ball of my foot and clear it, or I'll swing it way out to the side and make kind of a big wide arc with that leg that I can't clear. And like it says here, it could be combination of, or compensation for hip flexion, knee flexion, or ankle dorsiflexion. Any of those are valid for either of these activities. So whether it's excessive ankle plantar flexion or excessive ankle or excessive hip circumduction. Increased knee flexion. It's observed during loading response or terminal stance phases. This is typically where at the kind of end when they're getting ready to pick that leg back up off, they kind of have almost like a hunched knee where the knee is stuck in about 10, 15, 20 degrees of knee flexion. It's typically a problem with the knee itself that they're standing on, and it could be a contracture, could be knee pain, could be joint effusion. A lot of time you're going to see excessive knee flexion after a total knee replacement, where they're going to not want to straighten that knee fully out. And so when they take a step, obviously it's going to shorten the step length on the opposite side because they can't get a good clearance of that foot. So they're only going to kind of do a step 2 pattern. And that's going to overall not allow them to clear that other side, right? And they're going to take shortened steps. So it'll be, almost look like that antalgic gait pattern where, they're just kind of hopping a little bit to each other, hopping a little bit to each other. Could be to guarding for sure. Absolutely, Jaira. So it could be that they're guarding that other knee. Could be that they can't extend it at all, right? Could be a full-on contraction. Could be that the knee is so swollen they can't do it. So any of those could be valid. And so that's going to be one where we kind of have to look at. So if we're going through and we're like, oh, okay, so that right knee is stuck in flexion, then we've got to get them over to the table and see if we can even straighten that knee, right? Because if we can straighten it, then we know it's probably guarding. Right, if we can actually get it all the way straight and they're like, oh yeah, I can straighten when I'm sitting here. I'm like, oh, well, that means they're probably guarding because when they get to full extension, there's pain. Right, if we're like, nothing's moving, then we've got to figure out what's causing that excessive knee flexion, that stuck in knee flexion. Kind of the opposite of increased knee flexion is back knee or genu recurvatum. This is almost exclusively a weak hamstring problem. Theoretically, it could have some tight quads to go along with that, or excessively strengthened quads where they've got a muscle imbalance. But most of the time, the hamstrings are culprit here. So this is when they go into stance phase, and as they straighten that knee, it whips backwards and kind of looks like an ostrich leg is the best way to put it, or an emu, the emu. And the leg kind of goes backwards during stance phase. At that point, could also be genetic for sure, right? And it could also, they're also going to do a little bit of anterior pelvic tilt when they do it in order to allow that kind of go through. And when they swing through and they start getting to that heel strike, you'll also see a little bit if you're paying attention. Because as that heel strikes and that knee straightens out, you'll see a little bit of that snapping as well. So now we've got to get them over, test their hamstrings, right? Look at their hamstrings, see how strong their hamstrings are. Most of the time, we're going to find that they're like a 2+ or a 3 in hamstrings. And that means we got to strengthen those hamstrings. And we're probably also going to have to stretch a little bit of the quads as well to kind of overcome that muscle imbalance. So step edge gait, drop foot gait, tibialis anterior gait, kind of looks like a horse prancing is a good way of looking at it. That's when they kind of step and their foot kind of snaps up when they're going through gait. The idea here is it's either muscle weakness or paralysis of the tibialis anterior. And the way you'll know it is the clear sound when that foot hits the ground. Because when the foot hits the ground, you should have a nice isometric hold of the foot and then an eccentric load of the foot to allow it to roll through with the toe off. With somebody that's got this, when that foot strikes, you hear a nice clear slap, right? Or if they've had a little bit of control, you'll see it come down and just kind of drops. There's no eccentric control of it, or actually more, and there's no isometric or eccentric control. Like I said, it looks a lot like when they're walking, they kind of kick that foot up in order to get it in the dorsiflexion. So they're going to use basically almost like a front snap kick in the martial arts to kind of get that foot to snap back, so that when they plant down, they're landing on the heel. Otherwise, they kind of drag their toes and it doesn't work. So they kind of kick in front. It looks a lot like prancing when it comes to a horse, is the way I always remembered it. But there's definitely that clear kind of either the foot slaps when it comes down, or it just kind of drops and just drops down. There may not be a complete slap. Gastrocnemius gait, or otherwise known as Lego gait, is also the sore foot limp gait. So this is where somebody has probably stepped on something on the plantar surface of their foot. And so they're, again, this is not that their gastroc is tight, right? We've got that coming up with equinus gait. This is they've injured the bottom of their foot, or they have something in their shoe, or something's going on like that, and they don't want to plant down on that plantar surface. That's what gastroc or Lego gait. And literally, I'm not joking, your test questions may call it Lego gait, because this is the parents' worst nightmare. They're getting up in the middle of the night to go pee. They go through the hallway, and somebody left a 1x1 laying in the middle of the floor in the hallway, almost like an IED, right? And it's usually the 1x1 or the 2x2 or the 2x1s that are out there, because it's always the little tiny ones. And you plant that right down the middle of your plantar fascia. That's real life over here, yeah, right? You plant that down the middle of your plantar fascia, and the next like 5 minutes, you're walking around on the toes of that foot. Could that also be because of diabetic ulcers? Yes, absolutely, right? I could get diabetic ulcers that lead to that. Because remember, diabetic ulcers typically happen on the plantar surface of the foot. That's a C, I promise you. So that's the sore foot or the Lego gait. Again, if they call it Lego gait, that pretty much clarifies it. Oh yeah, it's because they stepped on something painful. Could also be the Hot Wheels gait as well, because they're just about as bad, except for the fact that their wheels are down, then you end up falling. So waddling gait, which Kelly had asked about, the Duchenne's muscular dystrophy and also Becker's muscular dystrophy. Waddling gait, if you remember way back when I talked about muscular dystrophy, when you have a patient that has muscular dystrophy, a lot of times when they're in standing, right, instead of standing here like a normal person, you see them drop their pelvis back almost into a posterior pelvic tilt, and they just stand like that. What they're doing at that point is not allowing muscles to hold them into gait. They're allowing your ligaments in your pelvis and also in your hip to hold them upright. And so they're kind of, it almost looks like a gluteus maximus gait, except for the fact that they're constantly leaning back. And so when I waddle like that. It's not a penguin gait at that point, where, you know, you're just kind of leaning over one side. At that point, you're just kind of lifting the hips up on both sides and not really clearing much space when you walk. Why is that? Well, because muscular dystrophy, yeah, it's that proximal to distal muscles weakness, right? And ideally, technically with muscular dystrophy, it's the distal to proximal muscle weakness, right? Meaning that the distal muscles are still functional, but the proximal muscles are gone. So their hip muscles or intrinsic muscles of the hip are just shot. And what they're trying to do is compensate with all their distal muscles. And as muscular dystrophy progresses, that waddling gait is going to get worse and worse until the point they can't walk anymore. Right? So their step lengths are going to get shorter. Their stride lengths are going to get shorter. It's going to take them longer to get places. So for that one, we're obviously going to have to correct them by getting them to stand upright if they can. But in reality, if waddling gait is all they can do, then guess what? We may have to just deal with that, because muscular dystrophy kids aren't going to get better. Right? So what could we give them? We may give them a walker, so that when they're walking, they have a little bit more safety, right? Because if I'm posteriorly displaced the whole time, and we know that kids fall backwards anyway, that's just predisposing me to falling backwards. Does that clarify the difference between waddling gait and a waddling person? Okay, Jara says yes. How about Kelly? Okay, good. There we go. There's my main one. And then we've got a couple neurological gait patterns. So these typically are spasticity related or flaccidity related, or ataxic, apraxic. So almost, well, at least the first two, as I say, almost all of these, well, even three down here. So these kind of three are typically seen in people with cerebral palsy. So hip adduction or scissoring gait. This is as the person's walking, the legs are closing like a scissors, and they're crossing over one another. So as they walk, they're coming across. So that's going to be primarily a hip adductor problem, right? So this is going to be that my hip adductors are tight. More than likely, it's more than tight. They're probably spastic at that point. So every time I pick up that foot to walk, they just kind of go into spasm and pull that foot inward. There could also be hip abduction weakness as well. But if I have one side that's spastic and tight, a lot of times the other side is eventually going to go weak anyway. So we're going to need to stretch out these hip adductors, right? Stretch. And probably strengthen our hip abductors. But if the problem is truly CP, is this likely to go away? So if the problem is really spastic cerebral palsy, are we ever going to fully get rid of it? No, right? I want to give you money for your pack. So that means that, you know, the most we can really do is lessen the impact of the scissoring gait on their gait. So kind of stretch them out so maybe they don't cross completely over. Because again, if they're crossing completely over each other, their base of support is like that. That's going to lead to falls. This equinus gait here, this is the #1 sign for CP. Especially in very young kids. So kids that are just starting to learn to walk. Now, almost every kid, when they first learn to walk, walks on their toes. Why? What has not integrated yet? What reflex? What reflex do we have in the foot that kind of causes plantar flexion due to stroking the foot? The plantar and the Babinski, right? The combination of both of those, actually. So good, right? So if you see somebody that's like, you know, just under 2 and they're still kind of walking on their toes, don't automatically go, oh my God, that kid's got CP. It could be just that not everything is integrated yet. But if we're now at 4 and we're still seeing that, and maybe we still have a positive Babinski, that's when we start going, oh boy, probably got some CP going on here. Because definitely by 4, that Babinski should be integrated. So at that point, this kid is literally walking on their tippy toes everywhere they go. That is what equinus gait is. And that's a I mean, there could be undiagnosed CP there, Adrian. I'm not diagnosing, so there could be. Especially if there's positive Babinski to tied with it. Because positive Babinski is an upper motor neuron sign, and so that typically indicates that we've got some CP going on as well. But it could also just be that it went untreated for so long, and her gastrocs are now just rocks, because I've seen that as well. Where, you know, kids, parents don't take them for treatment or whatever because they think it's kind of normal, and the kids' gastrocs just become literally like bricks. Yeah. And sometimes what docs hope is once the hormones kind of start leveling out in her when she hits puberty, that those hormones, because at that point she starts releasing a little bit of relaxin that naturally happens for females, hopefully that'll kind of calm down that gait pattern. Otherwise, she has a life in heels, I'm just saying. Hemiplegic gait is the gait of who? Who typically has hemiplegic gait? What type of patient? Strokes, yeah. So that's where you're going to see them kind of neglecting one side as they walk, right? I also think of hemiplegic gait as almost Lurch from, oh my God, Addams Family, the way he kind of walked when he walked, right? That's almost a hemiplegic gait. So they're kind of, you know, leaning to one side. They typically have one arm that's not involved with swing. The other arm's maybe hyper swinging to compensate, right? That's a hemiplegic gait where one side just isn't working very well. Ataxic gait. Remember, with ataxic gait, the motor plan for gait is intact, right? They're not apraxic, they're ataxic. But when they try to implement that plan and try to walk, nothing works right. So they're kind of all over the place. This can also be, like I said, it can be a CP gate. This can also be the gate of the drunks. Because when you drink too much, your cerebellum gets involved and gets kind of whacked out. And when it gets whacked out, your gait is kind of all over the place. Right? So a person who has ataxic gait pattern often looks like they're drunk. They're kind of all over the place. Their balance is off. They may go to one side when they walk one way. They may go to the other side when they walk the other way. It is definitely not a fluid gait pattern. They may have normal heel strike roll through on one side and be all over the place on the other leg. That's what ataxic gait means. It's just not a very coordinated gait. And then kind of the last pathological gait you'll deal with is Parkinson's gait, or bradykinesic infestination of gait. Parkinson's gait has two main components. Number one is that little short shuffling steps, right? They're using a ton of energy to get around, but they're not getting very far. Because for every 2 steps that we take, they take 40. The other problem they have is that festination, or that freezing of gait, right? Where they come to a change in surface and maybe it goes from tile to carpet. And at that tile and carpet interchange, they just kind of stand there and shuffle back and forth. And the reason is their visual comprehension of what's going on. Sometimes their brain thinks, oh my God, that's a cliff. And if I step over it, I'm going to fall. So the brain stops them. And you have to remind them, okay, let's go, take a step forward. And then they'll take a step forward and then they're fine. And they hit the next interchange and they're froze again. This can be really complicated if they're on like a tile floor that has multiple color patterns, because they may freeze at every change in color. And that can be really frustrating for the patient. Right? So with Parkinson's, we got to focus on posture, getting them upright and taking big steps, and maybe working with them on a metronome where they can take steps according to timing, right? There's just an article, I think it was in the Psychological Today, that talked about getting Parkinson's patients to walk with AirPods in. And so every time they go out and walk, they should have music playing, because there's something about music with Parkinson's patients that triggers them to walk normal. Now, I wouldn't recommend something like Iron Maiden or something like that while they're walking, because, headbanging and walking is never good. But something with an even beat pattern is really good. It'll take some good classical music, maybe not the Ride of the Valkyries, preferably 4/4, exactly. Yep. So that's it for pathological gaits. Does that help? Anna says yes. It does. All right. So joint capsules and capsular patterns. So the joint capsule itself, right, and capsular patterns. The joint capsule, if this is my joint, the joint capsule are all the ligaments that are wrapping around that joint. We're covering the joint over top and inferiorly. So the joint capsule itself is everything but the muscles. Because the two reasons, and again, if you look at the research kind of contradicts that there may not be such a thing as joint capsules, or not joint capsules, but capsular patterns. But it was interesting because I just taught this Monday to the other group. And I evidently have a whole group of PTs and PTAs and OTs that follow me on YouTube now. And when I taught it, it caused Wednesday night for there to be a phone call where we had like 8 people on the call. We were all arguing about capsular patterns. And what it came out about it was we found out that everyone believes there's capsular patterns. We just don't always agree about how those capsular patterns work. It was loads of fun. Like I wanted to go video game. I had to argue with PTs and PTAs that late. It was like till 11 o'clock. I'm not even joking. So what is a capsular pattern? A capsular pattern is a joint-specific pattern of restriction of passive movement. It indicates the existence of contractures of the capsule itself. So here's the thing. Capsular patterns can be helped by just stretching. This is why you have some people that say, well, capsular patterns don't exist. Because if I stretch the joint, if I just stretch the muscles, it goes away anyway. Well, duh. Right? If I stretch the joint, if I stretch something in the shoulder flexion, I'm going to stretch the inferior capsule of my shoulder. That's a dumb moment. With capsular patterns, there'll be a very specific typical pattern of the joint if the capsule is affected. Each joint has its own capsular limitation, right? And what could cause it? OA, spondylosis, stenosis, spondylolisthesis, rheumatoid arthritis, traumatic arthritis, whiplash, ankylosing spondylitis. Pretty much any itis could cause a capsular pattern, or any form of a condition that is traumatic to bone or joint. Capsular patterns are based on clinical findings rather than research. So this is going to be one where it's much more based on what we see in the clinic and less based on what is in research. Because research, it's really hard. It'd be almost impossible for me to get 40 people together that have capsular patterns in the shoulders to research them, because when you have a capsular pattern, everyone's capsular pattern is different. You know, we know that with capsular patterns, they're limited more in external rotation, abduction, and internal rotation of the shoulder than anything. But it could be that the person's limited a little bit in external rotation, more in abduction, less in internal rotation. And then the next person's more in internal rotation, less in abduction, and a lot in external rotation. And so there's not enough cohesive presentation of patients in order to do really good, solid clinical research. Now, there are plenty of single case studies, and there are even small cohort studies. And that's why, some PTs, Dr. Sokel is one of those PTs that says capsular patterns don't exist. She just doesn't feel that they're a real thing. She feels that they're more of a, they're just more of a clinical excuse for why a patient looks the way they do. And then there are other of us that are like, no, the capsular patterns exist. But the thing is, when she treats them, she's going to treat them with stretching and strengthening. She's just not going to individually focus on the capsule. And she may get a good result out of it, or they may come see somebody else that believes in capsular patterns and get a good result out of it, right? Your classic capsular problem would be something like a frozen shoulder. That would be your classic capsular problem, right? So if I have a capsular pattern, I am going to mobilize the joint. So this is a mobilized joint problem. I was going to hit that here. I just want to kind of cover what the different treatments were. If I have a non-capsular pattern, I'm going to stretch and strengthen. So what could be a typical question here? A board question on this might give you a question on the shoulder, because the two main joints you're going to get capsular patterns on are the shoulder and the hip. So if I am a betting person, I would know the shoulder and the hip patterns inside and out, because those are the two ones. So shoulder, external more than abduction, more than internal. So if I had a question that was trying to confuse you and convince you that it was a capsular pattern, I would say that I have a patient that is limited in shoulder flexion and extension. Which of the following activities should I do to treat this problem? And my headset just turned off for some reason. Don't know why. And so if I'm limited in flexion and extension, it'll say inferiorly mobilize the joint, superiorly mobilize the joint, stretch out the anterior and posterior musculature, or Move the patient into abduction. Well, if it's a flexion and extension problem, that is not capsular. So we do not mobilize the joint. So we are going to stretch and strengthen the muscles around the joint. But what they're trying to get you to see is you go down and see mobilize the joint. And you're like, oh crap. Which way do I mobilize when they have flexion and extension problems? And your answer should be, I really don't need to. Now, in the clinic, does that mean that a patient that's limited in flexion can't get some benefit out of joint mobilizations? No. I may mobilize the joint to calm down pain or to reduce spasticity, but it's not going to treat the problem. The problem is that they've got a stretch or strengthening problem. Or you may get a board question that says your patient is limited in external rotation to 10 degrees, internal rotation to 15 degrees, and abduction to 45. That is a classic capsular pattern of the shoulder. And then it's going to say, which of the following directions would you mobilize the patient? So I'm going to write it over here again. So I said 10 degrees of external rotation, 15 degrees of internal rotation, and 45 degrees of abduction. So my official answer to how to mobilize for this patient is yes. If this patient was seeing me in the clinic, my answer is, how do I mobilize this patient? Yes. Because the external rotation is the anterior capsule problem. The internal rotation is the posterior capsule problem. And my abduction is my inferior capsule problem. So pretty much I can mobilize that patient any direction and it's going to do them good. Does that make sense? That's why I said yes about it. Right? Okay. But what is my major problem? What is the problem that is the worst? ER, right? Because what's my normal ER range? Because remember, is ER less than IR? It's more than, right? Yeah, so I've normally got 90 of ER. I've only got 10, right? So that is my major problem. And what we'll find sometimes is if I fix that, guess what? The rest of this may resolve. Because even if I'm just mobilizing, so again, I said that ER problem is my anterior capsule, right? So how do I stretch my anterior capsule? Which direction do I go? Good, yeah. So I stretch the capsule the opposite. So if it's an anterior capsule problem, I stretch it posteriorly. Or mobilize it, I guess. I don't want to say stretch because that'll confuse you guys, sorry. I mobilize it posteriorly, right? If it's a posterior capsule, mobilize it anteriorly, right? If it's an inferior capsule, I mobilize it superiorly. Pretty rare in the shoulder that it's a superior capsule problem. Usually that's when we get slap lesions and stuff like that. It's always the opposite. So the question may say, you know, posterior mobilization, anterior mobilization, superior mobilization, or stretch lats out. We'll probably have two different stretches. So it'll probably say stretch, I don't know, teres major. So you usually have two stretches and two mobilizations in these questions. Well, technically, stretch lats isn't wrong, right? Because it might help, but that's not the best answer. Stretching teres major, I don't know how we do that. So that leaves me with the anterior and posterior mobilization. Well, if I know that external is my anterior capsule, I've got to posteriorly move it. So posterior move is my best answer at that point. Now, would this patient also benefit from anterior moves? Yeah. right? But in this case, it's not the best answer because I need to go after the most restricted motion first. Does that make sense on how the questions might be worded? Okay. Hello, Justin. Sorry, we're still going through the lecture. Abduction, right? Think about it. Abduction will be the inferior capsule because that's the one that's going to be tight when I go up this way, right? It's going to limit me going up. And that's kind of the idea. The capsule that's limited is the one we're going to mobilize. So I put all of your normal capsular patterns in here for you for the joints that are the most common. But if I am a betting person, I am studying the hip and I am studying the shoulder because those are the ones that are going to help you. Does that mean that you might get a question about wrist? Maybe. And in order to mobilize a patient with capsular pattern, what position do I put them into? Open pack. Good. Right, so that's why I included open pack there with these. All right, active versus passive insufficiency. I'm going to simplify this as much as possible. Active insufficiency, because I had a couple people actually ask me about this, which kind of surprised me. So I wanted to make sure I hit this. Active insufficiency, the muscle cannot contract anymore. Passive insufficiency, the muscle cannot stretch anymore. That's it in a nutshell. The only difference you may have is you have to pay attention if your muscle crosses one or two joints or has multiple motions, because the board is not going to ask you about active or passive insufficiency of vastus intermedialis. The board is going to ask you about active or passive insufficiency about the biceps femoris, or about, rectus femoris, or it's going to ask you about the biceps brachii or triceps brachii or something to that effect. It's not going to ask you about the easy muscles. It's not going to ask you about brachialis. So that's why I have one down here as an example. So for example, if it's asked about the biceps brachii on passive insufficiency, you have to remember all the motions the bicep does and reverse it. So the biceps job, primary job is elbow flexion, right? Secondary job is supination. Tertiary job is shoulder flexion. So in order to put, if I'm in this position here, I'm in what? Of the biceps. I'm all the way up here in the full, I'm in active insufficiency, right? I couldn't, if you gave me something and told me to move it, I can't move it. I've got no more range of motion in the biceps. That's versus passive insufficiency. If you had passive insufficiency, I've got to do the opposite. So I've got to extend the shoulder, I've got to pronate, and I've got to extend the elbow. And at that point, I'm putting the bicep on max stretch, which means I could actually stretch the muscles out in that posture. Are we ever going to exercise up to full active insufficiency? Meaning, are we going to cause them to take a dumbbell and be like, okay, bring it up like that? Does that make any sense at all? No, right? But if I'm going to stretch out gyra and I need that muscle to get maximally lengthened, I'm going to put him into passive insufficiency to get the best lengthening out of it. Right? I could stretch the biceps here in the elbow extension, right? But if I add elbow extension with forearm pronation, I get a little bit better of a stretch. If I add elbow extension, pronation, and shoulder extension, I get an even better stretch. So that's why it's important to think about what the muscles do. If you know what the muscles do, right? We know that rectus femoris, its main job is extending the knee and flexing the hip. So if that's the case, then we've got to flex the knee and extend the hip to put it in passive. And that gets the maximum stretch for that rectus femoris. Does that make sense for those two things? Again, active can't contract anymore, passive can't stretch anymore. Those are the basics of it. That's it. So if you get a question on the boards about it, you've got to look at your muscle and go, what does this muscle do? And am I asking, can I contract anymore or couldn't stretch anymore? That's it. I know that seems really simple, but really it is. I think the terms active insufficiency and passive insufficiency just scare people. And so they see that and they're like, oh my God, what are they asking? This is a complex topic. I'm going to die. And in reality, it's just, can the muscle contract anymore? Can the muscle stretch anymore? All right, cardiac pathology. Cardiac pathology, when we're talking about right and left-sided heart failure and then leading to ultimate congestive heart failure. The most common type of heart failure is left-sided heart failure. The most common type is left-sided heart failure. I'll say that again. The most common type of heart failure is left-sided heart failure. So I start talking with right because it's the least common. So if the right side of my heart, so the inside of my heart here, right, the more medial side of my heart, starts to fail, well, at that point, the blood returning to the heart is going to start backing up, right? My used blood collector is going to start backing up, which is going to cause the blood in my veins to start backing up, which means that my lymphatics are not going to be able to drain into the vein because the veins are already full with backed up blood. If my lymphatics can't do that, what's going to happen to the tissues? Yes, that's a good way. Erica made a good comment, right? Left side of the heart failure is lungs, right side of the rest of the body. It's a good way to remember it, right? But again, if my lymphatics can't drain, what am I going to get pretty much systemically? Edema. Exactly. Right? And primarily, I'm going to get it in the abdomen, in the GI tract. So I'm going to get a condition called ascites or ascites or however the freak you want to pronounce this thing, because I always get yelled at for calling it ascites. Ascites, when I think of that, I think of Africa. Why do you think I think of Africa? Yes, the kids on the commercials, right? The kids where you're just like, you know that the photographer that's filming those kids has a sandwich in his pouch. And those poor kids are starving. If you ever want to see something, by the way, Google Sam Kinison in desert. He has a great explanation for that. Sam Kinison usually had a lot of great explanations for everything. And for those who don't know, Sam Kinison was a comedian who liked to yell a lot, so I'm going to warn you on that. But so in that case, swelling is going to build up, and it's going to build up in the lower extremities as well. But right-sided heart failure is secondary to left-sided heart failure. And then once you get both of them failing, what do you go into? If both your right and your left side have started to fail, then you go into congestive heart failure. Yes. Right? This is where fluid's backing up everywhere. There are medications, I'm just going to cover this at the bottom. There are medications for congestive heart failure, but understand the ultimate term in any of these conditions is heart failure. What does that mean this person is going to do? This person is going to fail. They are likely going to die. Right? So this is something that a lot of people a lot of docs try to avoid talking about, especially if they've got heart conditions. They'll talk about, well, these medications can extend your life and blah, 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 blah. But they can't stop the heart failure. The heart is failing. There's just no other way around it. There's only one solution for heart failure. What's that solution? What do you think the solution? Yeah, transplant. That's it, right? And let's say that I go into heart failure tomorrow. Am I likely to get a heart? Yeah, no, I'm not. Right? Even though I'm younger, right? And I don't smoke and I do exercise, but I'm at this point where they'd rather give it to somebody who's like 20, who has their life ahead of them than me. It's the sad part, right? So they'll give me medications, they'll try to treat it. I may get the artificial heart, the Jarvik artificial heart, right? Which basically is a battery pump that I wear for the rest of my life. You know, and there are some interesting things on this. So there's some science that are showing that we might be able to 3D print a heart soon, which is actually kind of exciting when you think about that. That we may be able to take part of Erica's DNA, you know, take a bone marrow donation from Erica, put it into a 3D printer, and 3D print her a new heart. Wouldn't that be like? But the thing is we all know who's going to be the ones that benefit from that. Is it going to be you and I? Yeah, we don't have the, how do I put this politely? Well, not even our kids, Kelly. It's going to be the rich people's kids. I hate to say it. Because they're already estimating that in order to 3D print a heart, it's going to be somewhere in the range of $500,000 to $700,000. Do you think insurance is going to cover that? Probably not. Just saying. But what do I know? Maybe we can go to Costa Rica. And then we have left-sided heart failure, the most common. This is where it backs up, like Erica said, backs up into the lungs. It's a failure for the blood to pump out to the body. And the blood builds up in the pulmonary veins, causing shortness of breath, trouble breathing. And the big sign of left-sided heart failure is a persistent dry cough. So that's the person who's like constantly. Now, we get a little concerned if that dry cough turns into a wet cough. Why do you think we might get concerned if we know the person has left-sided heart failure and their dry cough becomes wet? Yeah. They're starting to get pneumonia. You're 100% correct, right? And they're starting to get fluid in the interstitial tissues. All right, so that's cardiac pathology. Neurology for right and left brain. And this is, you know, what happens if I have traumatic brain injury on my left side versus traumatic brain injury on my right side. Again, it's also going to depend upon where that traumatic brain injury is or where that stroke is on the brain, on what's affected. But typically, the left side of my brain is language comprehension. It also is proficiency at movements. It is production of language. People that are left-brained are typically analytical, want control, are very logical, are very rational, are very math and science-based, and have an easier time expressing emotions and process things very logical and sequential. Those are people that are typically left-brained. The people that are right-brained typically process things very non-verbally. They have what's called holistic processing, meaning they can think outside the box. The right-sided brain people typically are the outside the box thinkers. They usually have more artistic ability. They have a conceptual comprehension, you know, versus left-sided people, which are objective comprehension, meaning they can understand the facts. Right-sided people typically understand the whole concept of what's going on, but may not get the facts of everything. Typically, right-brain people have a better hand-eye and hand-foot coordination or eye-foot coordination. They're better at spatial relationships and kinesthetic awareness. They usually have a propensity for music. So I saw Jaira earlier. Maybe Jaira has a little bit more right brain than he is left-brained. Comprehension of nonverbal language. They have the reasoning of math and science, but maybe not the logic of math and science. They are better at expressing negative emotions. And when I say expressing, getting them out to other people. And they have a lot more body image awareness. They think of their body in a way that's a little different than the people that are, for left brain people, the body is just a tool. Right? The left brain people think more about their body than everything. So if I have a stroke or traumatic brain injury on either of those sides, it could affect people in different ways. If I end up with because I've had it where I've had a patient that has been definitely more right-brained. I am 100% left-brained. Like there's very little on that right side that applies to me. And the theory used to be, the old theory used to be, if you're right-handed, you're left-brained. If you're left-handed, you're right-brained. I don't know if any of you ever heard that term before. Or that phrase before. But I would contradict that because I'm left-handed. But then there's also theories that maybe I am left-handed and my left brain is on my right side. That I could just have a neurological swap of sides, which happens. But what would this mean? Let's say I get a really bad traumatic brain injury to the right side of my head, and I get one of those really nasty, just huge lesions in my head from a traumatic brain injury. If I'm one of those logical, rational persons, I might change my personality and suddenly develop artistic talent. Or I might all of a sudden have trouble doing math and science type stuff where I can't balance my checkbook. I can't do stuff like that. I'm going to use myself as an example. Back when I worked for Summerlin Hospital, I was free climbing up in Red Rock. And when I fell free climbing, and I literally cold cocked the side of my head on a rock as I fell down. And I ended up with partial amnesia from it for a couple of days. But the other thing I noticed was my hand-eye coordination was shot. I could not interact with things. I couldn't do anything like that. My hand-eye coordination was gone. My spatial awareness, gone. I'm walking around the house running into everything, right? And I was constantly thinking at that time my wife was mad at me because I was interpreting her nonverbal cueing totally different than she was giving me, right? Because I had a right-sided brain injury. And it was funny because I'm like, after it started happening, my left side of my brain started kicking in and started going, well, the reason you're having these problems is because you damaged the right side of your brain. So you have to be able to conceptualize why your right side of your brain. So I could totally this whole thing was happening at the same time. Like my left side of my brain was firing off, explaining why I was acting the way I was acting, which was like, to me, I'm like, this is the classic neurological case of this, right? Now that doesn't talk about frontal lobe versus posterior lobe versus, temporal and stuff like that. This is just a right and left split. Does that make sense for those though? I try to give you an easy list. There's a lot there, but most of that you've heard before. I don't think that was for anyone here, but that was for a request for someone else. All right, so that's it for the PowerPoint. Let me bring up this little Quizlet and see if we can get this working. It's the first time I've ever done this, so bear with me. I'm new at this. I've never taught before. Actually, I've never done present this in full screen. All right, so the website that this little Quizlet's on is slido.com. I think there's a Slido app as well. I don't know, we're gonna try this. I've never done this before, so please bear with me. We'll see how this works. But I put a bunch of questions into this and set up a timer for each of the questions. So, I mean, it should be pretty similar to Kahoot, except for the fact that with this, I can have longer questions. So just give me kind of a shout out when I know that you're ready to give this a try. Yeah, somebody joining. What is this? I love it. a couple people join in. Ready? All right. No, because they should pop up for you once I started here. So we'll see. This again, my first time using this, Dylan. So we'll see how this works. You're with me here as well. All right. So I'm going to start the quiz here. All right. So you think you should be able to join it now? Does it allow you to join now? All right. Look, I got some faces. La, that's got to be Kelly. All right, I'm going to start the quiz here. I have programmed in 60 seconds for each question, but I've got 20 questions here. We may not get through the whole thing. We'll see. I'm going to start the quiz. Are you guys able to answer it? Okay, cool. I just want to make sure I didn't know. It's my first test at this. I'm a virgin here. And I did 60 seconds because I wanted to make you feel what it feels like for an eternity. The 60 seconds sometimes feels like an eternity. Hold on a second here, because I need to bring something else up over here. I need my results over here. Sorry, forgot to bring the results up so I can see stuff. All right. So what is the correct answer there? Anyone know? Okay, Hector says inspiratory. Inspiratory is the correct answer. So the inspirometer, think of what it says. That's okay. It is an inspirometer. Yes, you have to suck in. Right, so it is an inspirometer. All right. Oh, it does show it there. Okay. All right, here we go. Next question. All right, so this is saying electric stimulator has an adapter. So all electric stimulators, all of them, are going to have the 3-prong standard plug. So they are not going to look like this. They're going to have that third prong. What does that third prong do? Does anyone know? that big round prong. Yeah, it's surge, it's the ground protection, right? So what this is saying is you've got an electrical stimulator with 3 plugs, but because your clinic doesn't have any of those 3 plug outlets, you plug something over it to make it a 2 plug like this one and plug it into the wall. Is that okay? Yeah, that's a no from me, dog. Right? Honestly, if you're in a clinic like that, you should not be using the e-stim machines, because it's very easy for a surge to come through that machine and literally electrocute your patient. Right? So in this case, it should be discontinue use of the stimulator. And honestly, that clinic manager needs to get a butt whooping from OSHA is what needs to happen. Does 60 seconds feel like a lifetime? Ooh, this one got a couple of you. What's my key word in this question? Or key phrase? Okay. Even more important, that is most appropriate. So, what is likely happening here? That's okay, Hector. You're not a problem. What is likely the problem here? Is this person having high or low blood sugar? It's typically hypoglycemia. But here's the thing. What are the symptoms for hyperglycemia? The same thing as hypoglycemia. Yeah. Booth is right. So what would be the most appropriate answer there? Nope. Yeah, check their blood sugar. Why is that most appropriate? That's okay. I'm just going to answer that. So why is that most appropriate? Like I said, the stuff that is high blood sugar and low blood sugar, when you're facing it in the real world, exactly. You don't know if it's low or high. Exactly. Good job, guys, right? Now, and we can't tell somebody to inject insulin, 100% Erica. Now, you may have seen this question before, but I modified it on purpose. Because the previous question was give the patient some sugar. But I modified this because the better answer is to have them take their blood sugar. Right? Now, what if they take their blood sugar? Well, it depends again, Erica. I mean, it depends. Honestly, if it's DM2, they probably have to take their meds. So they're probably carrying around meds that treat for emergent situations like this, whether it's low blood sugar or high blood sugar. But again, the best at that point would still be check their blood sugar first. I'm going to use my mom as an example here because my mom was DM1. And I came home the one night from work and she was confused, shaky, pale, sweating. Everything that I thought, yeah, I'm going to talk about that in a second. Everything that I thought was low blood sugar. So I gave her, the first thing I did was I went and I got a sugary soda and I gave her a sugary soda. And while she was drinking that sugary soda, I took her blood sugar. And when I took her blood sugar was 700. Yeah, it was literally smack this can of soda out of her hand. You're exactly correct. Right? And at that point, then it was appropriate for me to do what? Call 911. Yeah. Right? When would it be most appropriate to call 911? Like you said, patient passes out. Right? Over 300 is a good rule of thumb for sure. Over 300 and under 60 is usually a good rule of thumb. Because when you're under 60, it is not a long path until you pass out. Yeah, I've seen people that are like 59, 60, and then 3 minutes later they pass out because the body uses up whatever residual sugar they had left. So always the best answer is having the patient take their blood sugar first. So that way we can have an empirical decision on what to do about it. And let's face it, how long does it take to take blood sugar? 20, 30 seconds? Yeah, a minute maybe, tops. And if this patient is actually having hyperglycemia, where their blood sugar is really high, and I give them a sugary soda, what could I possibly do to them? Send them into, yeah, I can make it worse and send them into diabetic shock, right? And put them into a coma, which is what happened to my mom, unfortunately. My mom was so high, she went into a coma then eventually. And to this day, we still have no idea why her blood sugar was that high to begin with. Like, I didn't find like 5 cream pie cakes around the house that she ate or anything like that. She just, I mean, now my mom did drink a ton of Coke. Like, that's part of the reason why I drink Coke Zero is because, man, my mom drank a lot of Coke. All right. We're gonna have good results on this one. I know we are. I feel it. There are 2 that I would rule out immediately. Okay, well, at least we ruled out one of them. Okay, so good. No one picked neutral heat, because neutral heat does what to muscles? Relaxes them. We're trying to increase tone. Now, what is the other term for rhythmic initiation? PROM. Is that going to cause muscle contractions and get the muscle to increase in tone? No. What is prolonged? So if I'm ruling this out, prolonged stretch and neutral heat are out for me, because both of those are for relaxation. Rhythmic initiation is PROM, so that's not going to increase tone. The only one up there that increases tone is quick stretch. That's that pop motion that I showed you guys. Okay, let's take that a step further. Am I activating the muscle spindle or the GTO? Because the correct answer is quick stretch. I'm just going to tell you that. Okay, why am I activating the muscle spindle? You're right. What am I triggering? Okay, the muscle belly, good, but I'm triggering a very special neurological event from PNF. A very specific reflex. Motor things, good. You remember that term? The myotatic reflex. What's the other term for that? There's an easier word for that instead of myotatic. The stretch reflex. Good, yeah. Remember, because again, muscle spindle has two words. Myotatic reflex has 2 words. Stretch reflex has 2 words. That's okay. What is the GTO? Do you remember what the GTO reflex is called? Well, I'll give you a hint. Golgi tendon reflex, good, right? And then what is it in relation to myotatic? You remember what that's called? It also has a myotatic. Inverse. You remember this briefly from the, what do you call it? The PNF lecture, right? You have the muscle spindle reflex or muscle spindle, which triggers the stretch reflex or the myotatic reflex. They're all the same that work together. And then you have the GTO, Golgi tendon organ, which is the Golgi tendon reflex, which is the inverse myotatic reflex, because they have 3 words. So you're triggering that quick stretch reflex. And what that does is when I trigger that, if I'm flaccid, I stretch that muscle out. The muscle spindle says, oh my God, if you keep stretching me, I'm going to get damaged. So I'm going to contract. And that's going to increase tone. This feels like forever for me. Ooh. All right. So 2 of those I can rule out right off the top, and it looks like we ruled those off automatically. The A and the D we can rule out. 0 to 30 degrees of plantar flexion, pretty close to normal. 0 to 120 degrees knee flexion, for some people that is normal. So we got both of those out. So the answer is going to be the 10 to 45. Why is that going to be more functionally limiting than the 5 to 135? Yes, no neutral. Think about it when I'm walking. If I'm stuck in 10 degrees of plantar flexion, am I going to drag my toes? That keeps you on your toes, right? Now, that knee flexion may be problematic, right? That 5 degrees, but 5 degrees most of us live with on a daily basis. I'd be willing to bet, like, if I measure Dylan's knees, he's probably got between 2 and 5 degrees of knee contracture just from being an athlete. and he's able to get around just fine, right? But if his foot is stuck in 10 degrees of plantar flexion at all times, that means he has no dorsiflexion or no neutral even. That means every time he walks, he's dragging that toe. And we know that the only guy named Dragon is on Secrets of Skinwalker Ranch. I love this question because at this point, you're all freaking out. This is probably my favorite one. So I guarantee right now, Kelly is going, what the living hell is this? All right. So the answer is going to be cryoglobulinemia, frozen protein. Now, I'm going to give you a hint here. Do you really need to know what any of these diseases are? Okay, but I'm just saying, to answer this question, you maybe have to know what Raynaud's is. Exactly. The two clues here are cyanosis and Raynaud's. Because what happens with those conditions? What causes both of those conditions? Being what? Cold. And then I'm going down to my answers and going, which one of these has something cold in it? There's only one. Cryoglobulinemia. Yep. That's it. That's all there was to this question. And this is supposed to be hard, but it's more about, can you use the context clues to answer it? Because I guarantee very few of you remember what granulomatosis is. All right, so in the real world, what is this question asking you? In the real world, what is this question asking you? Which of these muscles is part of what? Yes, how to strengthen the pelvic floor. Which of these muscles is part of the pelvic floor? Only one of those muscles is part of the pelvic floor. And unfortunately, pubococcygeal is not that one. Pubococcygeal. What do you think pubococcygeal's job is? Pubis stuff. Nutation and counter-nutation of the pelvis. So basically rocking of the pelvis in its place. The only muscle that's part of the pelvic floor there is levator ani. All right, you weren't wrong, right? Pubis stuff. Because remember, when I gave you that lesson, I said you should feel what if you're lifting up that, if you're working on that pelvic floor, you should feel what happened. Should kind of feel your butthole kind of lift up in the air. Levator, right? Lifting up, ani, anus. I like being bamboozled. While you take this, I'm going to grab my allergy med real quick. I don't know if you can see in the background there, Gyra. I finally got my last part. It came in today. Power supply finally came in. Finally put everything together. All right, let's see. I actually have a test power supply from MSI. That is their new platinum series. It says gold on because that's all it's certified for right now, but it's an 850 platinum. All right, so diabetes mellitus 2, does it have anything to do with HDL? What is HDL? High density lipids, cholesterol. Yeah. So it has nothing to do with blood sugar. Now, could they have an increase? Sure, but that's not what the goal is. The goal is to reduce their use of medications. Because honestly, it's 100% possible that if you're diagnosed with diabetes, excuse me for the belch there, if you're diagnosed with diabetes 2 and you exercise, magically, guess what can happen maybe a year later? You may not have to take medications. That's okay. That's why we're doing this, Dylan. This is not the real test. I'm glad this actually works a little better than Kahoot. I may actually use this more frequently now. Is the app side of it, your side of it, pretty easy to use? I haven't used this yet. Still, okay, good. All right, I better get 100% here. That's annoying music too. Oh, no, annoying music. Okay. I said it had to mute. Okay. All right. So we got it down to the correct 2 choices. I'm happy about that because number A and letter A and letter C, or number 1 and number 3, have nothing to do with this, right? That means the person's normal. And Erica should be able to tell you that number D has nothing to do with the stress test. What does that have to do with, Erica? What are we taking to look for an arrhythmia? We're looking for an EKG. Yeah, 12-lead EKG. Right? So if they're getting a stress test, we expect them. And now, does that mean the EKG might have led us to believe they have ischemia? Sure, it could have. Right? But a cardiac arrhythmia is not detected by a stress test. That's gonna, and now they may be on the EKG and they may find it while they're on the stress test. But the ischemia is the reason they're going in for the stress test. They're worried about there being a problem with blood flow to the heart. Oh, we better get 100% on this one or I'm going to have some problems. I'm going to throw this spiky ball at some people's heads here. Because there's literally only one on there that is the right answer. Only one on there that involves the shoulder. Oh, somebody better have changed their answer. So the only one that involves the shoulder there is prone on elbows. Does that mean short-seated you can't have your hands out? I mean, sure, you could, but it doesn't say short-seated with bilateral hand support. It just says short-seated. I'm short-seated right now. My shoulder uses nothing. Right? The only one that involves shoulder approximation, the shoulder joint being closed off, is prone on elbows. Oh, this one's for Gyra. All right, we're all over the place here. All right. Jared, did you get the right answer here? That's okay, but did you get it? All right, so PFT is what? Because that probably might have thrown a couple of you off. You're like, I don't know what that is, so I'm just going to pick it. I said PFT, not the ABG. ABG is arterial blood gas. Good job. Pulmonary function test. Exactly. That's how much air you can breathe. I mean, that could lead to chronic respiratory acidosis for sure. Like if your pulmonary function's not working. But first of all, we have to figure out how to identify it. And that's an ABG analysis, right? That's arterial blood gas analysis. Graded exercise testing, not going to tell us anything. That just tells us how strong they are, how much energy they have, how much their endurance is. And what does pulse oximetry only tell us? Basically how their hemoglobin's working, right? How much oxygen is actually in the blood. That's not going to tell us if they're in acidosis. The only way we will know if they're in acidosis Yep, it's the lab for the lungs. Exactly. So we're going to see how much carbon dioxide and how much oxygen actually is in the blood with the partial pressures. Oh, we just talked about this. I better get 100% here. Looking at you, Kelly. Looking at you. It's a wording that always gets you. That's the point. That's why I'm doing this. My key word there is equinus. The hemiplegia doesn't matter. Yeah, so in this case, you could be worried about the hemiplegia, which then with the weakness muscles could be right? But that's not the key word here. The equinus is the key word. Equinus is when you're walking on your toes, which is excessive triceps surae. And I specifically changed that to triceps surae to get a few of you, which means that it's not only the gastroc, but also the soleus. If I had excessive tibialis anterior activity, what would happen? What would I be walking around like? With my foot in what? Yeah, walking around my heel. Yeah, right, dorsiflexion. And what does tib post do again? Tib post is, right, tib post is a weak plantar flexor and it's pretty strong in everter, right? So weakness of tibialis posterior, actually, we wouldn't be doing cauda or equinus gait. And then let's face it, what does plantaris do? Absolutely nothing. Plantaris is kind of like, oh my God, the palmaris longus in the hand. That's pretty much what plantaris is. It really doesn't do much of anything. I mean, it helps, but for the most part, plantaris is useless. I changed this question up just a little bit to make it a little bit more clear if you've seen this question before from me. Thanks to that little, I never thought of that actually. That's a very good acronym there, Erica, so that should help somebody out. All right. If a patient complains about distal extremity pain, specifically, when does their distal extremity pain get worse? If the problem is intermittent claudication, walking, or when the what? Legs are elevated. What condition causes intermittent claudication? PAD. Yeah, peripheral artery disease. Right? So if I elevate my legs, right, there's my legs, now my arteries struggle to get that blood up to the feet here. So if I've got distal lower extremity pain and I'm looking at the dorsalis pedis pulse, I'm looking to see how strong their pulse is out there to see how bad their peripheral artery disease is. Hypertension, not really matter. Pulmonary embolism, they'd be dying. Cor pulmonale, they're actually going to die as well. But what's the sign of cor pulmonale? You remember? It's right ventricle. Good. Right? Because it goes along with right-sided heart failure. Edema in the body, good weakness, super high blood pressure. Right? And sometimes they get that really kind of shrill whistle when they breathe. Like, and it's not something like, it's not like, sometimes you get that kind of wheezing whistle when you breathe because you've got a cold. It's like literally they're whistling when they breathe. That's because everything's starting to back up and nothing's going to the lungs, and the lungs are starting to choke off. But swelling's a big one, right? Cor pulmonale is an emergent condition that needs to go to the hospital. Is intermittent claudication an emergency condition? No, they just have to learn to deal with it and live with it and adjust their lifestyle. Stop eating Taco Bell. This is going to go right along with a few of the other questions we had here. And see what happened here. Ta-da! All right. What medication would they be on if they had DVTs? Coumadin or heparin, or what would be the X that they may be on for that? Because there is one X that they may be on for that. Because I think that may have thrown at least one of you off. There is one X for blood clots, and that's Plavix. So I'm hoping the person that picked there's people that picked DVTs were confused because they thought, well, it's got to be Plavix. What does Lasix cause you to do? Yeah, like pee like a fountain. It's kind of like going out really late and drinking lots of cheap beer. Lasix drains out swelling. So if you have congestive heart failure, Lasix it is a diuretic. Yeah, Lasix is designed to help you empty out all that extra fluid. Let me ask a side effect question here, and we'll see if you guys get this. Would LASIK also put a little bit more demand on the heart? Yeah, it would, right? Which is why they've got to have other medications, not just the Lasix. Because the heart's got to still filter all that fluid and get it to the kidneys, right? Get it through the blood supply, get it back out to the kidneys so the kidneys can kind of drain it out. So yeah, it's still going to cause a little bit of excess thing, which is why they've got to be on some sort of heart medication as well. Oh, I got some of you here. So perceived exertion. Remember that perceived exertion is kind of like a EKG for the heart. Perceived exertion is just that time frame. 6 minutes is a long time, right? 60 seconds seems like a long time right now. When we are doing the 6-minute walk test, we obviously elapsed time has nothing to do with it. We know that's 6 minutes. Heart rate response, not really a concern. What our goal is to see how far the patient can walk in 6 minutes. That's the point of the 6-minute walk test. That will determine the patient's overall endurance. That's the point here. Because as I work with Gyra, if Gyra is my patient, and I do a 6-minute walk test today, in a month, when I do the 6-minute walk test, his distance should be greater, right? And a lot of times we may have to do these stupid tests outside because the patient doesn't want to walk on a treadmill, which would be the easiest way about doing it. But they're like, I don't like to walk on the treadmill. I'm scared of those things. So you got to go walk outside back and forth on the freaking sidewalk for 6 minutes. But we're looking at how far does the patient go? We're almost done. 16:20, we're on the home stretch. All right. So here's the deal. A demand type pacemaker and a superficial metal implant may be a precaution only if we're doing e-stim away from them. We don't know that. So at that point, they would be hard indications. And active bleeding, we definitely don't want to do e-stim with, because if we do e-stim with that, typically they're going to bleed worse, even if we're doing wound care. What does decreased mentation mean? Because that may have got a couple of you. Like, what's mentation? Mental ability, yeah, right? So just because a person isn't mentally aware, it doesn't mean we can't do e-stim with them. It just means we're going to have to do what? Are we going to be able to do unattended? Yeah, we're not going to be able to do unattended. We're going to have to do attended e-stim the whole time. The other three are hard contraindications, especially in the area those exist. And the demand type pacemaker actually is probably a hard contraindication for all e-stims, I think, at this point, because demand type means that it fires off when the heart needs more and more stim. So if you kick up some e-stim, there's a likelihood that that thing may just not fire. All right, this one you guys should get. I hope.
God, seems like it takes forever. Oh,
I'm gonna cry. Transduction I just made up. Now, the thing that, and the reason I made that up is the thing that you're using is called a transducer, but transduction doesn't exist. You forgot the word piezoelectric. What does piezoelectric mean? Does anyone remember? Electricity created by a what? Crystal and one other component, not magic. That'd be like Harry Potter electric. Ultra sound, yes, wave, right? So piezoelectric is basically creating an electric current, really, and what we're doing is creating heat via sound waves through a crystal. But I like that. I thought you made up piezoelectric. That's great. At least no one picked magnetic energy. Obviously, we know that magnetic energy doesn't exist because we live on a flat Earth. It's not working well today. Got two more. You guys can make it. Are these sufficiently hard enough for you, Kelly? All right. Dun, dun, dun. I don't know that excessive hunger is really even a sign for hypoglycemia. I can't remember. I don't think so. The only thing that I know excessive hunger is a sign of is Cinnabon and Prader-Willi syndrome. Those are pretty much the only two things that I know that are signs of excessive hunger. Because I guarantee you, even if you're not hungry and you're walking through the mall, you smell Cinnabon, suddenly you're hungry. Yeah, that's an insane disease, isn't it? Prader-Willi's is kind of crazy. The way that basically your DNA makes you eat too much. It's really what it is. But at least maybe the Cinnabon is only me. I don't know. Every time I smell Cinnabon, all of a sudden I'm hungry. All right, this is going to test me here. This is a wound care question. Only one of those is right. Optimus Prime says you better get it right. If you don't get it right, I'm going to come after you. and he's got an axe, he'll create a wound for you. Oh, please, please. Oh, we're all over the place. that could not have been more evenly delineated if one person had moved somewhere else. That's I'm sorry, that's fantastic. Language, Mr. McKeever. Language. I almost slipped. Okay, so the only thing. Yes. Actually, that was exactly where I was going with it, Erica. You just beat me to it. I think the same thing. I think of venous ulcers like zombie bites. They have goo coming out of them. They're often yellow and pussy, right? And there's in the D&D world where I play, because I play D&D, zombie bites also can cause paralysis, so that you don't feel the pain from the zombie bite. And they're typically located on the medial side of the leg. Typically at the medial malleolus. But that's exactly the way I remember them too, Erica, believe it or not. And we actually I just had a class on this, and that was the way the guy directed. He's like, so when you're thinking of thinking of a venous ulcer, he's like, think of The Walking Dead. Because think about it, when they get bit, oftentimes they don't feel the pain because they're too tough and too cool. So they don't feel the pain. And it's got yellow gunk all over it. And it causes this fibrous buildup. And oftentimes they're running away. So the zombie bites them in the ankle as they're running away. And the only place they can bite them is on the inside. And that causes a jagged wound. I was like, huh. He said that, and that has now stuck in my head. Remind me to tell you the funny story about the pelvic health class I took after we take this last question, because that'll make you all laugh too. So I took 2 continuing education classes recently, and the pelvic health one was great. All right, last one, SCI. It's a chance to redeem yourself. I'm hoping I get one of 2 answers here. If I don't get it exactly right, everyone gets it right. I hopefully get one of 2 answers. All right, good. I got one of 2 answers. I'm happy for that. All right, so what led you guys to the complete? No sensory motor, specifically at S4, S5. Good. Yes. Right, that is the definition of a complete spinal cord injury. No sensory motor at S4, S5. So once you get that, so the way I'm breaking down this question is I see no S4, S5, I'm automatically going complete, and I'm going down here and crossing these 2 out. My next comment is paraplegic. Para meaning how many limbs affected? A pair, so 2 limbs. The only one that is pure 2 limbs is T8. Now, could this person that's a C6 not be a full paraplegic? Or quadriplegic? Sorry. Yeah, I mean, they may still have some function in those shoulders. But that's not the best answer, right? And you got to remember on your boards, it's the best answer. And the best answer here is T8. All right, let's see how we did. All right, so if we were taking the boards, let's see here. If we were taking this and this was the boards, why is my calculator so damn large? Move it over here where I can see it. 20 times 0.68. So if you're taking the boards, you would want 13.6 out of 20 or 14 questions correct to get a 600. That's we'll use that as an excuse, Kelly. It's okay. I'm just joking. So the hardest question was the diabetes one that no one got correct. All right. Let's stop sharing. Did that help some of you guys? Kind of looking at the questions and going through them? Did that help, Kelly? Because I know you specifically requested that. And we can do that again next week too. I can put some more together for next week as well. Yep. Well, no, don't let it bring you down. What it does is it means that you've got to work. So if there are any topics that you guys would like to be added to next week, please let me know. And I may just change the whole next week into this because it seemed like it worked out well. I will also give you guys a link to that Slido so that if you want to go back and review those questions, you can go back and review them. I've just got to figure out how to do that. I'm not quite sure how. I'll learn. I think there's a way I can do it. I just got to figure it out. If not, I'll just create a PowerPoint out of it and post it. Real funny story just to kind of end on Tuesday. PowerPoint is up in that the Google Drive folder that I have created. Do you have that? Do you still have a link to that? If not, I can get you the link really quick. I think I still got my Google Drive brought up here. Hold on. I will just grab the link really quick. Get link. Oh, no, I want the link, you stupid thing. Copy link. There we go. That's got all of the previous ones as well. So real quick, funny story. Like I said, I was in a course for internal pelvic strengthening. And there was me, there's about 7 or 8 women, and there were 2 other guys in the course. I will look at, I can look at them in a second. Yep, let me get a second. And we got to the point where they're like, and sometimes guys have pelvic floor issues. And so she breaks out this model of a man, or like a actual plastic model, and she goes, and so in order to test for internal strength of the pelvic floor, you have to tilt their body this way and insert your fingers, and all of a sudden you hear, so-and-so has left the call. So-and-so has left the call. Both the other guys badassed out, and they just left. They were not about that at that point. It was great. Let me look at the questions you sent me, Miss Kana. So you had asked, so one of the questions she asked is, a physical therapist assistant performs a muscle length test for the long head of the biceps. Which of the following findings is most consistent with shortening of the muscle? So what this is asking, when you're looking at that one that you just sent me, that one there particularly, Sakana, when you're looking at that one. So let me see if I can bring this up in another window here real quick. I may just have to download these really quick. There we go. Put this over here. So she sent me a handful of questions that she's having questions on. So let's take a look at them. If you've got questions on them, somebody else does too. Move them over to another window here, just so I can get them out of my mail, because I don't know what I have open in my mail. I don't want to reveal any trade secrets. If there's anything like that in my mail. There's typically not any trade secrets because I'm not that cool, but you never know. Erica was trying to get some trade secrets out of me the other day. Just joking. All right, share screen. Let's go over here. So let me make this just a little bit bigger. So physical therapist performs muscle length tests for the long head of the biceps, which of the following findings is most consistent with shortening of this muscle? So what is this asking about that we just kind of covered in the PowerPoint? Yeah, this is acting about active and, well, this is actually acting about active and passive insufficiency. So this is saying my long head of my biceps, which is the one that crosses over the shoulder joint, right? That's the key thing you need to look at here. It says, okay, so it's crossing over the shoulder joint. Shortening means active, right? So that means anything with extension is ruled out. Because extension means what? Extension would be lengthening that muscle. So anything with an extension, that one has extension, that one has extension, that one has extension. All three of those are ruled out. The only one that has combined flexion is D. It is a hard question. But does my logic make sense? Right, I know this is a hard concept to grasp. This is one where I'm going, okay, so this would be one where I'm going, okay, so I've got long head of biceps. What are my motions? So I'm going elbow, flexion, shoulder, flexion, radial, ulnar, supination. Okay, so I need at least 2 of those in order to get active insufficiency. Does that make sense? And then if I'm thinking, well, to go, so that would be for active insufficiency. For passive insufficiency, I'm going, well, I need extension, extension, pronation. Well, I'm going for active insufficiency. That's what the question's asking about. So the question's asking for active insufficiency. So anything with extension is out, period. Because that's going into passive insufficiency. So toss those questions out, those answers out. The only thing I'm left is 4. I know I made that really simple, but it's a complex question that is really simple. That question was designed to tricksy you because you're so worried about this. And honestly, you're probably thinking more about the capsular patterns, you know. You're going, oh my God, well, this has nothing to do with capsular pattern. It's just talking about muscle length. That's it, it's just muscle length. And whenever you see muscle length test, I want you guys to think active and passive insufficiency. Don't think capsular pattern. Because if it's saying muscle length test and it's talking about lengthening of the muscle, you're going into passive insufficiency. If it's talking about muscle length test and shortening of the muscle, active insufficiency. That's all I want you to think. That's it. Don't worry about the capsule. Don't worry about blood flow. Don't worry about anything like that. You're just worried about active and passive insufficiency on that question. Put me on the spot here having to answer questions right off the cuff. Physical therapist assistants, because I didn't see these until right now. Physical therapist assistant suspects the patient's upper extremity range of motion limited may be a result of fear-based psychological response. Which of the following examination findings would be most consistent with this? All right, so fear-based response, what end field? Good, pain or empty, good. Right, so this patient is not going to want to do it. Empty end field. So I'm looking through here And well, so I know that I've got empty and I've got pain. So one of the things I can rule out right off the bat are these two answers, because they both have pain-free in their answer. They're both out. I'm going, okay, I got a painful response here. They're both out. So then I've got to figure out, so the last two are, how much is this resistance? If I'm doing fear-based, I am going to avoid doing anything. So I'm going to have decreased range of motion, and I'm not going to want to do the resistive training, because what am I afraid of getting worse? Pain. Yeah. So I'm worried, I'm worried that my pain's going to get worse. Now, if I've got somebody like Dylan, who's like a boss, and Dylan's like, I ain't afraid of no pain. Dun, 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 dun. And Dylan may just be like, but Dylan doesn't have a fear-based pain response at that point, or a fear-based psychological response. Dylan's just got the, if there's no pain, there's no gain response, right? So, but this patient's like, I ain't doing this crap. So the best, I ain't doing this crap response is this one. Now, would this patient have more passive than active range of motion? Yeah, almost all of us do, right? I guarantee if I take Hector and I lay him down and I test his shoulder flexion, I probably can get close to 180. But then when he does it himself, he may only get 165. Just because it's not he's resisting it, it's just that when he tightens up his muscles, he gets those swollen, and he gets some resistance there. All right, that's kind of why I use Hector, by the way. Does that one make sense, Takeda? And again, if you have these questions, somebody else does too. All right. Oh, we got spinal cord. Ooh, I have seen this one before. Physical therapist discusses the process of learning to drive with an adaptive van. I want to say that either Jira or Justin or somebody else sent me this one before. And I don't remember who it was. One of you guys. I can't remember. It was one of the guys. I know that for a fact. Oh, no. I don't remember who it was now. I forget who it was. Somebody, it wasn't the two, but it was somebody else. There was somebody that sent me this. It was probably Clarice, because Clarice sends me everything. A physical therapist assistant discusses the process of learning to drive with an adaptive van with a patient who sustained a spinal cord injury. What is the highest spinal cord injury level that this would be a realistic functional outcome? So, which one of these can I rule out? Only one, yeah, I can rule C4 out. Because literally at C4, the only thing I have is pretty much respiration and shoulders. So the big question, and this is common, so this is not only you, because it's the same person that sent me this, whoever it was, also picked T3. So you're not alone. Because you're thinking T3, they've got full arms, right? Is that what you were thinking? Right? Let me find this. I sent somebody a video on this. I have to figure out who it was. But so with C6, what motion do I have? What motions do I have? Do I have shoulder function somewhat? Got biceps? Do I have some delts? Yep, I got some upper traps too, right? Got some flexion, extension, and abduction. Good, right? So I've got this type of motion. Well, what's interesting is the adaptive, and I'll see if I can find the video on it, but the adaptive van for this actually has hand control for gas and brake over here. For pulling, basically pull, and that's actually pull in this way. So brake goes this way, pull goes gas. And then it has a little wheel over here for turning that they can go into abduction and use flexion to turn the wheel. So it is C6. This would just be one of those that you're like, well, I've never seen an adaptive vehicle. Right, I've never seen one. And I'll send you the video on this, because once you see the way the guy drives with it, because the guy that's driving actually is a C5. And he can get around town. Now, the highest level, yeah. The highest level meaning what neurological level could he be? So what do you think they're letting happen? You're right. He doesn't have functional hand fingers. I mean, he has wrist. Not floppy. Do you remember what that grip's called they're letting to happen? You have some functional grip, not total. What's that functional grip they're letting to happen? Because remember, C6 is also riding the motorcycle. Do you remember what that's called when I let my fingers contract? So when I pull back, my fingers hold on to it. Tenodesis or tenodesis. And you'll see the video that I have to find it. Now you're challenging me. YouTube. And I think if you see the video, Sukane, it'll make more sense to you. And when it's saying highest level, what it's saying is, how far up the spine can the injury happen and the patient can still drive? C6, drive. That's going to give me the C6 spinal cord injury. And there he is. There's the C5, C6 guy. All right, let me find this video, because this, you'll see his tenodesis grip. So there's the video for it. It's actually a really cool video. And the first time I saw it, I was like just blown away. So when it says highest level, don't get totally confused on that. What that's saying is, how far up the spine could that injury be and they still could drive? Right? That would be like me saying, changing this question up and saying, your patient is independently breathing. What is the highest spinal cord injury level where this activity would be a realistic functional outcome? Good, C4, yeah. Right, or let's change that and say, your patient is going to stand at a stander. What is the highest realistic functional level that could be there? So standing at a stander. What would I need to stand up there? I would need minimally the hips, because the knees are going to get locked in the stander. So what level would give me hip function? Anyone can. Okay, L1, right? L1, maybe, yeah, I would even hasten to say like L2-ish would be best, but L1, L2 would be the idea there, right? Does that help make sense of that?
Yes, Mr.
And like I said, I think if you watch that video is kind of cool watching that dude drive around. Like, it blew my mind.
Oh, thank you.
Oh, God. Ankylosing spondylitis. A patient diagnosed with ankylosing spondylitis exhibits forward stoop posture. Does the ankylosing spondylitis have anything to do with this question? Nope. All that's there is to make you go, oh God, ankylosing spondylitis. What is that again? Oh God, I can't remember. Is that spondylolisthesis? Oh my God, I'm so confused. Has nothing to do with this question. Sorry, I just didn't pay attention. What is the important part about this question? best, good. PNF pattern, and then forward stoop posture. That's it. Those are the three things. So it's asking you, if I have a leaning forward posture, what is my best PNF pattern? Right? So let's think about this. Here's D1. Is that going to help? Either extension or reflection. Either of those going to help? Nope. I mean, maybe if I do bilateral D1, it might help, D1 extension, right? But if I've got a forward stoop posture and I do D2, flexion, remember it's happened at the shoulder, I do D2, I instinctively extend back a little bit. So how would I answer this question? Well, first of all, I'm sorry, I'm just going to say this. I would just know this one because I've worked PNF so long, right? So it's hard for me to just separate that part of my brain out and go, well, it just makes sense to me, right? So how would be a good way to answer this question if you got this on the boards? What should you do? Do it. Yeah, right? So I'm going, okay, so D1 extension. D1 extension is this way. Yeah, no, that's going to actually encourage me to stoop forward. All right, well, D1 flexion. Not really. Not really. Okay, that's out. So then I'm down to D2. Well, let's see, D2 flexion's coming here. That's actually encouraging me to kind of stoop forward. Ho ho! Oh, look at that. Ho ho! And especially if I do ho ho. Right, if I start doing the Russian hat dance. Oh, that's recorded. That's scary. Never mind. That is not allowed to be clipped. Glad I'm not on Twitch. That would have been bad. Somebody would have clipped that on Twitch on me. I know they would have. Does that make sense, though? Okay, so for when I have this question here, I am just going to go, did the ankylosing spondylitis throw you off? Is that what got you?
No, I just get confused between flexion and extension.
Did you get kind of stuck on that?
Yeah, I know it's going to be leaning forward. The track going to be interiorly, like it's leaning. So you have to.
Or you just didn't get it?
Yeah, it was stupid.
Ankylosing meaning that things are closing off. That's all it really means.
Yeah. Okay.
All right, we got one more. Physical therapist sits a positions patient as shown image to assess the patient's report of complete paresis of the right lower extremity. Assistant instructs the patient to perform a rapid straight leg raise with the left lower extremity. All right, so it's basically asking, my problem is I've got paresis of the right lower extremity. Paresis is what? Because you got weakness, good, right? Inability, right? But it is not paralysis, right? Just remember that. And it's not paresthesia, right? Which would be lack of sensation. So I'm looking at this and I'm going, okay, is there two that I could rule out? Because I'm seeing two I can rule out right away. Which two of those could I rule out? The pain ones, good, right? Because I don't know enough about that. Could they have pain? Absolutely. But paresis doesn't automatically, yes, it is Hoover. Yep, you're correct. But you don't even have to really know that, Dylan. Right, so this is basically saying, okay, so the good news is you didn't pick the pain ones. The pain ones just are out because, I don't even know why they have pain on there. So the patient is unable to lift their heel from the assistant's hand. Why would that be a problem? Yeah, Hoover's special test. It's an odd special test. It's not one that you're really going to get questioned on. So why would we not want the patient to try to lift the heel from the hand? Let's just go there first of all. Think about that logically. what muscle would flex the hip? Yeah, you're trying to prove the patient wrong, Justin. That's exactly what you're trying to do. And you're not, and again, this is not to go nanny boo boo, right? Good. 4 would be the contender, right? 4 could be a contender, except for the fact there, Justin, is we don't have enough to go. Thanks, Kelly. We don't have enough to talk about pain. So that's why I'm ruling that one out. There's nothing up there that talks about pain. So pain's not even an option at this point. Does that make sense? It's not like it's saying paresthesia plus pain.
So I guess my question is,
That makes sense.
aren't they able to do a full straight leg raise? Are we
Pain's not
assuming-
even one of the things we're considering right now. It could be, right? But here we're not worried about it. So Erica has it right. Hip flexion is primarily the iliopsoas. Is that a lower extremity muscle, really? No, that's a what type of muscle? It's truly a pelvic muscle. So if I push down with my heel, what isometric activity am I doing? What's that set called? It's not necessarily a quad set for that one. Push down with my knee, I would be. Ham set. Yeah, that's a hammy set. Is that a leg muscle? Yeah, right? Could I have done quad set as well? Could I have put my hand under the patella and said push down into my hand? Yep, that would be a valid way. Could I have limited the pelvic motion and had them try to do a heel slide? Sure, right? But again, if they're saying they have paresis, super weakness, they're not going to be able to do the heel slide. I want to get that trace. And what we're trying to do is say, look, I know that you have weakness in this leg, but we can do this, right? This is basically what you're trying to do is provide the patient with a glimmer of hope. That's what this question is really doing. Because when the patient hears paresis, they think paralysis, and they think life is never going to get better. We're trying to use this technique to say, look, you can do this. You're not totally dead yet. I think I'll go for a walk. But yeah, you're basically having the patient do a ham set here. Whereas this is, and this actually says patient's unable to lift the heel from the assistant's hand. That would actually prove it. Now that I look at that anyway. I read that totally wrong. I thought it was the patient's able to lift the heel from the hand. I read that totally wrong. Still, either way, I got that one out. Patient's unable to lift the hand, that technically proves a little bit, right? We want to disprove it. Best dispute. Making them do a heel ham set is the best way to dispute it. Does that make sense, Sukana? Did I lose you? Okay, good. Were those the only ones you sent me?
Yes, thank you, Mr. McKeever.
Okay. Is there anything else, folks? Folksy. All right. Justin, just hang around for a few seconds because I just saw your test. So I can talk to you real quick. Other than that, you guys are free. I'm going to stop recording. Have a good rest of your day.